Assalamu alaikum. The link clinical consultation day. The first scenario, Mr. John Smith, 70 years old male, presented with short of breath. Please take history, examine him, and address his concerns. Yes, you can start.
Okay. Hello, my name is Dr. Al-Mahdi. I am doctor in medical ward today. Can I confirm I am talking to the Mr. John Smith, 70 years old?
Yes, doctor, that's me.
Okay, Mr. Smith, we are here to ask you some questions as examine you and address your concern. That's okay with you?
Yes, doctor.
Can you tell me what brought you in clinic today?
Doctor, I noticed that for the past 3 months, I've been having shortness of breath. On little exercise, I became breathless.
Okay, you mean the worsening by the exercise?
Yes, doctor, yes.
Okay, once you start, it was sudden or gradually?
It's been gradual, but recently
Gradual.
got worsened.
Okay, is it worsening? Is it the first time or you had previous attack?
No, this is the first time, doctor.
Is it the first time? Okay, this is the shortness of the breath on the line flat?
No, doctor.
Okay, an increase, you said an increase in the exercise.
Yes.
What is improved?
Well, when I rest, I feel much better. Just that I get worsened when I try to do some activity.
Okay, the shortness of the breath increase when you on the flat.
You say what?
When you flat into the bed.
Yes, just occasionally. Yeah, but I don't really think so.
Okay, the shortness of the breath awake from the sleep.
No, doctor.
Okay, how many pillow are you using?
Just one.
One. Okay, any history of leg swelling?
Any?
Leg swelling.
No leg swelling.
Okay, any history of chest pain?
Yes, I have chest pain. Okay.
Since how long?
Chest pain. Just about 6 months ago.
6 months ago. Where exactly the site of the pain?
Just in between my chests, on the left side.
Okay. Can you describe the nature of the pain?
It's sometimes dull. Yeah, it's just there, dull, doctor.
Okay. Does go on to anywhere else?
No, I've not noticed that.
Okay. Denoted. Okay. What make this the pain is the worst?
When I try to get active, the pain gets worse. But when I rest, I feel much better.
Improve it. Okay. I'm sorry. There's into any special time of the day you feel the chest pain?
At all time.
All the time. Okay. Any history into the awareness into the heartbeat?
Yes, doctor. Yes.
Okay. Regarding the awareness of the heartbeat, any missed beat?
I'm not quite sure, but my heart is racing. I'm not quite sure about that.
Yes, you feel your heart is fast or slow or any missed beat?
It's fast, occasionally slow.
Fast. Since how long?
Just I can't really say. I would say about a month ago.
Okay. Okay. Do you notice anything making to the awareness of the heartbeat is worse?
No.
Anything is improved?
No.
Okay. Any history of the syncopal attack?
I've had a fall before, just once.
Okay. Since how long?
Just once. That was about last week.
I am sorry for that. Do you have any history of cough?
No cough.
Any coughing of blood?
No.
Any nosy chest?
No.
Okay. Any history of high body temperature?
No.
Any change into the weight?
Yes, doctor. I've noticed that I've lost some weight.
Lose the weight since how long?
For just about 1 month ago, I noticed that my trouser is getting loose.
Okay. How many over how long?
I'm not quite sure, but I noticed that my trouser is getting loose.
Okay. Is what intentionally or not intentionally?
No, it's not intentional.
Okay. Any recently changed into the diet or exercise?
No, doctor.
Okay. What about your appetite?
The same.
The same. You mean your appetite is decreased?
No, it's the same. Nothing has
The
changed.
same. Yes. Okay. Any history of tiredness?
Yes, doctor. I feel tired. Extreme tired.
Yes. In special time of the day or all in the day?
All the time.
All the day. Okay. Any history of night sweat?
No.
Any lumbar bump to the anywhere?
No.
Any dizziness into the sitting or standing?
I feel dizzy, especially when I stand up.
When you stand up. Okay. Okay. Any history of weather preference?
No.
Any history of neck swelling?
No.
Any recently unwell
No, doctor.
or infection?
No.
Okay. Anyone comment you better than before?
Any what?
Anyone comment you better than before?
No one has told me that.
Any bleeding from the any side?
Well, doctor, I noticed that I've had a bleed before when I poo, but it's not quite it's not quite worrying, but it's just that my poo is black. I don't know. It's not quite worrying.
From where side you are bleed?
From my back passage, doctor.
Back passage. Okay. Since how long?
Oh, well, it's been on and off for about 2 years now. I've been having this bleeding from my back passage. It's been on and off.
Okay. On and off since 2 months.
2 years, doctor.
2 years. Okay. Did you seek any medical advice?
No, because it's not really worrying. So I just thought it will go.
Okay.
Mm.
Okay. Any history of tummy pain?
No, doctor.
Any tummy distension?
No.
Any change to the bowel habit?
No, doctor.
Any passes into the black tarry stool?
Yes, doctor.
Since how long?
Just about the same time, just 2 years ago. It's been coming on and off.
The same time. Did you seek any medical advice?
No.
Okay. 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 Do you have any problem to the water work?
No, doctor.
Any frothy or increased amount or decrease?
No.
Any joint pain?
No, doctor.
Any skin rash?
Yes, I've had some blisters on my body, on my skin, or some rash on my skin.
Since how long?
About 2 months.
Where exactly the site of the rash?
It's just everywhere on my body, but it's more on my knee.
Okay. Okay. Can you describe the rash? Is it flat or raised?
They are flats.
Is flat. Okay.
Mm.
Related to the trauma or not, or spontaneously?
They just occur on their own.
What?
They occur on their own. It's spontaneous, doctor.
It's spontaneous. Okay. Any morning stiffness?
No.
Any difficult to the combing the hair or sitting up from the chair?
No.
Any headache?
No, doctor.
Any weakness?
No.
Any problem with the sensation?
No.
Any abnormal and unsteadiness gait?
No.
Okay. Any bleeding from any side? You said no. Okay. Okay. Any medical history I should aware of?
No.
Okay. Any recently admission to the hospital?
Well, not quite recent. About 6 months ago, I had this vomiting that was serious, and I had to vomit blood. But that was managed, and I was better.
Okay. Did you seek the medical advice regarding the vomiting of the blood?
Yes, I was told that I can't remember what I was told then, but I had some procedure, a camera test, and I learned that they did the procedure at that time. And since then, I've not had any bleeding from there was no
You
vomiting
mean you
of
didn't?
blood.
Okay. You mean you didn't see any the camera test?
I had camera test then, and I was told that they did some procedure at that time. And since then, there was no vomiting anymore.
Okay. What's your
And
diagnosis regarding the camera test?
I learned I have some growth that was removed during the camera test.
Okay. After that, you are follow up?
Yes, and I follow up, and I said I was okay, I was fine, And since then, I've not been going to the hospital anymore.
Where exactly the site of the the overgrowth?
It was a camera test in my tummy.
Okay. Any recently admission to the hospital?
No,
Any history of a blood transfusion?
no.
Show me the medication list.
I'm not on any medication, doctor.
Any over-counter medication?
None.
Any allergy from any medication?
No.
Any recreational medication?
No.
Okay. Are you recently traveled?
No, doctor.
Okay. Do you smoke?
No, doctor.
Do you drink alcohol?
I don't.
Do you drive?
Yes, I do.
What's your job?
I'm retired.
Okay, and what is the previous job?
I was a chef.
Okay. Okay, how much this is symptom affecting to the daily activity?
I'm just tired, and this is quite worrying because I can no longer walk my dog. I can no longer help my wife in the house, and I felt like I'm becoming a burden to her because she does most of the house chores. I can no longer help her anymore.
Okay. 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 Are you using? Sorry for asking this question. Any needle sharing?
No,
Any tattooing?
no,
Any history of yellow discoloration to your eye?
no.
Okay. Can I examine you?
Yes, sure, doctor.
The vital sign.
The pulse rate 100 beats per minute. The regular, and the blood pressure is 100 over 60 minutes of mercury.
One blood pressure. One. Sorry.
160 minutes of mercury.
Any butcher drop, blood pressure sitting or standing?
No, no difference.
Oh, no difference. Okay. Examine to the hand if there's any clubbing, if there's any cyanosis, palmar erythema,
No,
the eye of Baller and jaundice.
no. There's pallor, but
the
no jaundice.
Baller. Mouth of cyanosis.
No,
The neck of the lymph node and GVB.
no lymph node, no JVP elevated.
The lower limb, if there's any lower limb swelling.
No,
If there's any sign of DVT.
no.
Any history of family history of the same illness.
None that I'm aware of, doctor.
Any family history of blood clot or any previous history of a clot?
No, doctor.
Okay. I want to examine the chest.
Okay.
Auscultation, if there's any murmur.
Yes, there's murmur that radiates to the carotid. In the aortic area, goes to the carotid.
Okay, systolic murmur, you mean?
Systolic murmur.
Okay. Okay, any other murmur?
No.
Regarding to the S1 and S2?
First and second heart sound.
Okay. Regarding the basement to the lung, any crepitation?
No crepitations.
Okay. I want to examine the abdomen if there is any. I want to examine the abdomen if there's any organomegaly.
No organomegaly.
Okay. What's your concern?
Doctor, I'm
2 minutes left.
That I don't know. Putting all this together do I have I'm just worried. Is it cancer? What exactly do I have? I'm worried about cancer, doctor.
Okay, Mr. Ahmed, regarding to your symptom that you have, and after examine you, most probably you have a condition is the called Haidi syndrome, is the medical term for the medical condition due to the disease affected in the large bowel, leading into an increase into the bleeding and also association problem into the heart gate. What we need to do now, that we have a condition, okay, leading to the lose a lot of the blood, for that leading to the symptoms such as awareness of the heartbeat and shortness into the breath. For that, needing to do some blood. For that, you need to admit you and do some blood test and the imaging to confirm diagnosis. And after that, I will refer into the group specialist, include the heart doctor, gut doctor, specialized nurse, to provide it to the proper management plan. Do you have any other concern?
Yes, doctor, I'm just thanking for what you've said, but do I have cancer? Do you think it's, I don't know.
Your worry is understandable. The cancer of the one of the differential diagnosis. For that, you needed to some blood test to to rule out. Are you getting me?
Yes, doctor.
Any other concern?
No, no, thank you.
Okay.
Okay. Any more concerns?
No consent.
Okay. Examiner questions. You can start now, Dr. Ayula.
Okay. Can you summarize your patient, this patient, please?
Yes, 70 years old. This gentleman, 70 years old, presented with history of the shortness into the breath, sense into the 6-month association to the chest pain and awareness into the heartbeat, and also history into the bleeding in form of melena and blood passage from the back passage since 2 weeks. On examination, the patient, there's a systolic murmur to the aortic area radiating to the carotid. Most probably, you have a condition is the called Haidi syndrome. You needed the investigation to confirm.
Okay, so what investigation are you going to do to confirm the
Uh,
diagnosis?
Yes, the first of all, I want to do the basic investigation, CBC to confirm to the anemia, liver function test, renal function test, coagulation profile, and serum electrolyte. I want to do abdominal ultrasound, and also I want to do ECG and echo for the systolic murmur. And regarding to Haidi syndrome, you need to do colonoscopy.
All right, so what are your differentials?
The second differential diagnosis may be patient anemia related to the underlying malignancy, because the patient has history into the weight loss over 6 months.
Any other differential?
Other differential diagnosis,
Okay, so what are the components of Haidi syndrome?
Haidi syndrome, angiodysplasia, okay, and aortic stenosis.
Okay, all right. And how will you manage this patient?
The manage of this patient pharmacological, non-pharmacological, patient education and counseling. You need to admit into the patient because the patient symptomatic anemia, and depending into the patient hemoglobin, if patient need into the blood transfusion or not. Regarding to the Haidi syndrome, is it treated? I think by the angioplasty. I am not sure.
Okay, so what kind of anemia do you see in Haidi syndrome?
Normochromic normocytic anemia.
Okay, and do you know the pathophysiology of the anemia?
Pathophysiology of the anemia, I think due to the factor Val-Wilbraham factor is destructed in the ascending colon. The patient increases the risk of bleeding.
Okay, and the pathophysiology?
I'm not sure.
Okay, all right. Oh, thank you. Well done. That's what question I have.
Okay, it's still 2 minutes, so we can ask more questions. You mentioned general and baseline investigation. Any specific investigation you want to do?
Regarding to the anemia or regarding to Haidi syndrome?
Both.
I think regarding syndrome, colonoscopy and I think
about
Val-Wilbraham factor level. I think, yeah, I'm not sure.
Okay, the hemolysis workup, does it need?
For what? Hemolysis?
Hemolysis workup.
Okay.
You mentioned it's normocytic normochromic anemia, right?
Yes.
What type of the anemia? What the pathology of the anemia?
Regarding the anemia Haidi syndrome,
Yes.
I think because destruction of the red blood cell
So hemolytic
during
anemia, right?
hemolytic anemia, I am not sure بصراحة.
Yes, hemolytic. Okay.
Okay.
What are the workup for hemolysis, you know?
Yes, if the patient hemolytic anemia, you need to do the LDH and the haptoglobin, the indirect bilirubin, and the retics, and ultrasound abdomen, and peripheral blood film.
Haptoglobin, you mentioned haptoglobin?
Yes, haptoglobin, LDH, indirect bilirubin, retics, and peripheral blood film.
Okay. And the liver function test already mentioned in the baseline. Okay. What
Yes.
image you will do for this patient? You mentioned?
Colonoscopy.
And no image, not invasive.
Imaging. ممكن ultrasound and ultrasound abdomen and CT abdomen.
What type of CT you will use?
CTBA, CT angio.
Yes, CT angio.
CT angio, yes.
Because you suspect angiodysplasia, so it's in the visual.
Yes, angiodysplasia, yes.
Okay, I think fair enough now. 5 minutes. Dr. Ayula, you can comment, then I will comment.
Okay. Well done. That was a great presentation, I must say. Able to rattle your way back to another system entirely and put everything together. It was a good presentation. The history taking was great. Lovely history taking. Okay. But just one thing that I just want to, when during the history taking, I love the way you went about talking about the whole the history of shortness of breath, the cause and everything, looking for the cause and eventually landing in the history of the bleeding. That was great. Addressing of concern. You didn't really put more attention in addressing concern of this patient. I put forth to you 2 concern, and I have to prompt you again about one of them, and the second one you didn't attempt at all, and that was issue of affecting my family, not able to help my partner at home helping my partner at home. So I'm not quite sure. Could you how would you have addressed that concern in this situation?
If you have family affected the family?
Yes.
Yes, because this disease is runs into your family. There's a chance your family to have the same illness.
No. What I mean is affecting my relationship with my partner in terms of helping my partner who just the social aspect of it, not. Do you get what I mean?
No. If you ask about if the disease
social only, social. Yeah,
social,
not
the social thing.
Yeah, social issue.
Social issue. You need. يعني
with her partner at home. Yeah, with her partner at home.
You want to say him about the disease?
No, it's affecting my relationship with my partner. Like I can no longer help my partner.
No, this is not affected. It's not affected the relationship into your partner.
No, it will affect because of anemia.
Why?
Patient feeling tired from any efforts.
Yes, but regarding the relationship, the patient is not affected. The disease is not affected.
No, in general, in systemic way, not in a specific way. Dr. Ayula, this is what you mean?
You mean the disease?
Yes. What I mean is, during the history taking, one of the concerns I raised was I'm having issue with my partner as I'm unable to help her at home anymore because of the tiredness. Do you get what I mean? Like it's more like a social thing.
Yeah, not
Is
only
there a way
coping with daily activity for himself, even for the partner as well. You got it, Dr.
Yes, but the disease is treatable. Yes, disease is treatable.
Okay,
yes, you mean the patient can do daily activity because the patient suffers from.
She wants you to address this concern. Okay,
yes,
in
but
this way. So,
yes.
Yeah, after blood transfusion, maybe the patient will be fine.
The disease as treatable condition. You have the symptom of you can't do the daily activity because the low blood but the
Out.
disease
Yeah.
is a treatable condition.
Okay. Okay, what I was just trying to say is like looking
Hello?
at the social aspect of of this young man, like, of this elderly man. Like, is there anything that we can offer? I'm not quite sure. I just want to learn. Like, is there
Yes,
anything we
yes,
can do?
yes. By the way, Dr. Ayula, sorry to interrupt you. She asked you, what about the impact on your daily activity? And you said, yes, I'm not able to do my daily activity.
Mm,
Supposed to address it immediately. So we'll try to help you in this way. If she has another time to ask who's living with you, who's dependent on you, she can ask about the partner as well. You got it. So
yeah.
if it's already addressed for the patient himself, it's fair enough. If it is even affecting the partner, she can address it as well.
Mm-hmm.
Clear?
Okay. Yeah.
Yeah.
Okay, so moving on to the medical aspect of it, to the medical aspect of it, the other differential will has been an isolated aortic stenosis in this man, okay, because we are not quite sure whatever she's having from the back passage is blood or not, though she had a previous history of upper GI bleeding, which support more of the Aedes syndrome. But an isolated aortic stenosis could be a differential in this man until we have other investigation to support it. And for the Aedes syndrome is a triad, not two. Though eventually during the discussion, you mentioned that the von Willebrand aspect of it. So it's von Willebrand disease, aortic stenosis, as intestinal angiodysplasia, which can be upper or lower. It can be anywhere along the GI. Okay, and the management of it, of course, the investigation is you did well in the investigation. The axillary investigation, the calculation study, the echocardiography, the colonoscopy, CT angio, fantastic in this. But the management is aortic valve replacement. Once the valve is replaced, all the symptoms settles. It has excellent response to the valve to the valve replacement. So that is the ultimate treatment, valve replacement. Once you have the valve replaced, every other symptom settles. So
Okay.
basically, that is it.
Yeah.
Okay.
Carry on. Carry on. Yeah. Yeah.
Okay, basically that is it. And we also found that most of the patients that they address the GI symptoms, most of them don't get better compared to those that they address the cardiovascular with the valve replacement, they do much better. So that is the management of Aedes syndrome. So basically, that is it. Well done. It was a good presentation, I must say. Well done.
Yeah, thank you, Dr. Ayul. I agree with you. Dr. Rasha was very systematic and organized in her question from the start. The systemic review, the constitutional symptom, she asked every single question about the case. And she got to diagnose as well. But just few comments regarding the name of the patient. At the end, she mentioned Mr. Ahmed. So as general advice, not for Dr. Rasha only, whenever you forget the patient name, you can say either ma'am for patient as female patient or sir for the male patient. Okay, so you can make it as a vague word, ma'am or madam, and sir. If you forget the name, if you can remember the name, so it's okay. You can say Mr. John Smith, but don't give another name. Means that you are not focusing on the patient data. The other thing in the differential, and it was one of the concerning points. She asked you or he asked you about the possibility of cancer, and you give her or give him, yes, possibility is there, but don't say it's one of the differential. He doesn't mean he doesn't know what the meaning of differential diagnosis. So you can say it's one of our possibility in your case, as well as in the differential diagnosis. While answering the examiner question, you can put cancer colon or colon cancer, one of the differential diagnosis. The patient is losing weight, feeling pale, dizzy. So it's almost one of the constitutional symptoms and alarming signs and symptoms. And the cancer, one of the possibility, we should roll it out by doing colonoscopy, as you mentioned, or even the CT will show us if there is any mass. Otherwise, it was perfect performance from Dr. Asha, Dr. Ayula as well. Also the most important here in this scenario, I agree about the definite management to be the symptomatic aortic stenosis. We should replace the valve. So you can put the option at the end after stabilizing the patient, transfusing blood, checking all alarming signs, the cause of bleeding, all the image and invasive tests. Then at the end, the definite management will be aortic replacement after multidisciplinary team approach. Okay, don't forget to stabilize the blood by transfuse. I don't have any more comment, Dr. Asha. Really, it was perfect as systematic and organized history taking. This is the best performance you did in the sessions. You have any question, Dr. Asha or Dr. Ayula?
No.
No, thank
يعني
you.
التريتمنت aortic replacement وانجو وسي تي انجو صح؟
Yeah, CT angio. First of all, ABCD approach. Patient is
Yes.
symptomatic anemic, right? Symptomatic anemia. So he should be corrected as an anemia, I mean, transfusing blood. If there is push hypotension, you can start him in crystalloid. And if there is coagulopathy, of course, you have to correct the coagulopathy by giving either FFP or whatever a patient needs. If there is a cardiac issue, such in this scenario, aortic stenosis should be replaced, the valve itself. What do you
Yes.
think the best way to replace the valve in such age, Dr. Rasha? It's a question, general
I
question.
think that, yes, and Hayidi valve replacement.
No. What type of valve replacement? What approach you will do? What type of valve replacement you know?
Yes, yes, regarding this patient, you need the prosthetic valve, you need a tissue valve.
Okay.
Tissue valve.
Yeah, tissue valve is the preferred one, but there is
Yes.
another new technique for aortic stenosis, particularly in elderly patients who's not fit for surgery or any or
Therapy.
anesthesia.
Therapy.
Exactly, yes.
Therapy.
So transcatheter, yeah, aortic valve implantation, right?
Yes, yes, but
Right.
I think in Hayidi you need to remove the valve.
Yes, implantation means there is new valve, but by the catheter approach.
Yes, 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 yes.
Okay. Okay. Anyone has a question? Any raised question, Dr. Ayula? Your scenario down in the chat box. You can
Okay.
read. Female, Mrs. Julia. This Julia, 25 years, person with abnormal movement. Be ready. We can start when you are ready. Anyone with question, please, you can raise the question.
السلام عليكم دكتور باسم.
عليكم السلام ورحمة الله وبركاته.
في البداية جزاك الله خير على مجهودك.
Thank you
Thank
too.
you Dr. Rasha and thank you Dr. Ayuna also.
Okay.
Just I have a comment.
Yes,
Dr.
doctor.
Basim, actually, investigation of angiodysplasia, the gold standard investigation is capsule endoscopy, not lower GI endoscopy.
Capsule,
Capsule
yes.
endoscopy, because
Yeah.
most of the patient has small intestinal angiodysplasia. So
Perfect.
capsule endoscopy is the best in this situation.
Perfect, Dr. Ahmed. Thank you.
And also sometimes there is involvement, renal involvement in angiodysplasia. In
Yes.
this situation, we need to perform renal and CT angio. It will show stress beer signs, but it's not diagnostic because it's also in fibromuscular dysplasia.
Okay. So you mean there is a possible complication might affect the renal visit? Yes.
Yes. I mean, if in case of extra intestinal angiodysplasia, we need to do CT angio. In case of intestinal angiodysplasia, most probably it's small intestinal angiodysplasia, so we need to do capsule endoscopy. In case of renal involvement, we need to do CT renal angio also.
Yes, you mean it can affect the kidney vessel.
Yes, yes.
Yes.
Okay.
So it will be presented with hypertension, for example. as
Yes,
renal artery
hypertension
stenosis.
and rising creatinine.
Yeah, renal impairment. Yes, you're right.
Yes, it's my comment. Thank you.
Thank you, Dr. Ahmed. Very nice comment. Remember always, not in this scenario particularly, in any scenario, you have blood loss through the intestine and you did the upper endoscopy and lower endoscopy, you didn't diagnose or you didn't reach the cause, and still you suspect something in the small bowel, as Dr. Ahmed mentioned, the capsule endoscopy and the best way to diagnose any abnormality in the vessels or in the lumen of the small bowel. Why? Because the colonoscopy reach maximum, maybe near to the ileocecal junction, but it cannot proceed advanced. Okay, in the upper endoscopy as well, you can reach to the duodenum, assess the duodenum, but you cannot access distal to the duodenum. So the best way is the capsule endoscopy. It will show you the all lumen from the duodenum down to the rectal. Okay, thank you, Dr. Ahmed. Again, Dr. Rabia, there is a question. What is the type of this skin rash? I think this is a hemolytic Maha, right?
I think as the part of bleeding.
Bleeding or microangiopathic hemolytic, right? No, this is like purpura, right? Yeah,
For
it's
the
like
rash, right? Yeah, it's more like the Von Willy Brown thing, the platelet, the low platelet bleeding, the purpura
yeah.
thing.
So purpura, yes, purpura,
Mm.
yes. Yeah, thank you. Thank you for the question as well, Dr. Rabia. Or Rabia, Dr. Rabia, sorry for pronouncing wrong. Okay. Ready, Dr. Ayula?
Yes, please.
Yeah, okay.
Hello.
Hello?
My name is Dr. Ayola. I'm one of the doctors here in the clinic. Can I confirm you are Miss Janet, 25 years old?
Yes.
Okay. I understand that you are here to see us because you have some concern about movement. Is that all right? Is that right?
Yes, doctor.
Okay, could you tell me more about this?
Yes, doctor. Recently, I feel abnormal movement.
Okay. And how long has this been going on for?
Since 4 months.
Okay. And if you say abnormal movement, what exactly do you mean?
Doctor, like I do some abnormal movement. I can't control my my arm.
Okay.
دكتور باسم انا نزلت الفيديو مش عارفه كيف انزله في الجروب. Okay.
Okay, is it just your arm?
No, doctor, in all my body.
Okay. And when it started, did it start suddenly?
No, doctor, start gradually.
And do you think it has been worsening?
Yes, doctor.
Okay. Is there anything that make it worse?
No, doctor.
And is there anything that make it that improve this abnormal movement?
I am not sure.
Okay. And is there anything that you've done so far since it started?
No, doctor, no anything done.
Not anything done. Okay. And apart from this abnormal movement, do you have any other other symptoms? Any other symptoms? I mean.
Like what, doctor?
Okay. Do you have headache?
No.
Okay. And any issue with your sight?
Any what?
Your sight, your vision?
No, doctor, no.
No. Okay. Have you noticed any weakness in your body?
No, doctor.
Have you noticed any pins and needles?
No, doctor.
Okay. And have you noticed any stiffness?
Stiffness? No,
Yes,
doctor.
in any part of your body? Okay. All right.
No.
Have you noticed any difficulty with swallowing?
No, doctor.
Okay. Any swelling in your neck?
No.
Any lumps and bumps in your body?
No.
Do you have weight loss?
No, doctor.
You don't, okay, all right. And any night sweating, Miss Janet?
No.
No, okay. All right. Have you noticed any difficulty with walking?
Yes, doctor. I think my gait is not stable. Unsteadiness, doctor. I feel my gait is become unsteadiness.
Oh, I'm sorry about that, Miss Jane. Let's and have you ever had a fall?
Yes, doctor, once.
How long ago was that?
Yes,
When
doctor,
wa-
just only once time I have the fall.
Okay. Could you tell me what happened at this? What circumstances surrounding this fall?
Yeah.
Okay. What were you
Yes.
doing when you fall? When you fell?
Just doctor, when I try to go trying to the walk in my home, I feel lost the balance and fall in the ground.
Okay. So, did you by chance injure yourself in any way?
No, doctor.
Okay. Did you lose consciousness?
No.
Any abnormal movements? Jacking when this happened?
No, doctor.
Okay. When was your last meal before the fall?
The last one since 1 month.
I mean your last meal when you had the fall. When was the last meal?
Doctor,
Food.
just only once time.
Okay, all right. And did you notice? Do you have any dizziness?
No.
No dizziness. Okay. And we notice. Have you noticed any abnormal? Have anyone complained about anything in your eyes? Maybe some certain form of deposition. Anything in your eyes? Any concern about your eyes?
No, doctor.
No. Okay. All right. Okay. Could you you have anything about your do you have chest pain?
No, doctor.
Are you aware of your heartbeat?
No.
Any shortness of breath?
No.
Any swelling in your legs?
No.
Are you coughing?
No.
And because do you have any tummy pain?
No.
Any illness of eyes?
No.
Okay. Is your bowel like?
No, doctor. I don't have problem to my bowel.
Okay. What about your waterworks? Any concern?
No, doctor.
Any pain in your back?
No, doctor.
Okay, and just a little bit about your past medical history. Anybody for any medical condition?
Like what, doctor?
Okay, like any are you maybe some form of previous history of abnormal movement like seizures?
No, doctor.
Are you on hypertension,
Hypertension? No.
diabetes?
No.
Okay, and are you on any medication?
No, doctor.
Okay, have you got any family history of any this form of abnormal movement?
Yes, doctor. My father have the same.
Okay, and when was he diagnosed? At what age was your father diagnosed of this?
I think at the age 50 or 40. I am not sure.
Okay, and how is your dad now?
Now my father is die.
Oh, they accept my condolences, Janet. Okay, and apart from your dad, any other person with a similar thing?
Yes, my father have the same abnormal movement.
Okay, all right. Janet, how is your mood like?
Yes, doctor. My mood all the time is bad.
Oh, there. And on a scale of 1 to 10, 1 being the lowest mood you've ever had and 10 the highest mood you've ever had, where will you put your mood like on that?
Doctor, sometime 10, sometime 9.
Okay, so your mood is always high. Is that what you mean?
Yes, all the time my mood is low. All the time I feel depressed.
Oh, there. I'm so sorry about this. And what do you do for a job, Jeanette?
I'm a teacher.
Okay. How are you coping with this?
No, doctor.
Oh, there. And have you got any concern about memory? Maybe trying to remembering things and anything?
Yes, doctor. Recently I noted that I have problem in my memory.
Oh, and how long has that been going on for?
Yes, the same period.
Okay. Have you seek any help for this?
No, doctor.
Okay. All right. And have you got any joint pain?
Joint pain? Yes, doctor. Sometimes I have joint pain.
Okay. All right. So, Janet, do you take alcohol?
No,
And do you smoke cigarettes?
no,
Okay. And have you noticed any weather preference, Janet?
no.
Okay. Has anybody complained about your behavior? I'm so sorry to ask about this. Maybe people have started to point to you that your attitude towards them has changed in one way or the other. Anything of such?
Yes, doctor. My husband said to me, my behavior is changed.
Okay. Is it that you are more aggressive or you are more keeping to yourself or
Yes,
something?
doctor. Yes, doctor.
Okay. All right. Okay. Okay, Janet. All right. Janet, could you tell me how is your period like?
The regular.
Regular. Okay. And have you ever been pregnant?
No, doctor, because I am using pills now.
Okay. What sort of pills are you using?
I don't know. The doctor, the woman is give me some pills. The woman doctor.
Okay. And how long ago have you been using the pills?
Since 1 year.
Since 1 year. Okay. All
Mhm.
right. All right. So, Janet, just a quick question about your father. I'm sorry to bring back the memory about your dad, okay? Just that it may help us in arriving at a diagnosis, okay? Could you tell me what were the circumstances surrounding the death of your dad? I'm so sorry to bring this back.
What, doctor?
The circumstances around the death of your father.
I don't know, doctor. I don't remember, but I think my father has the same. It's in the same problem, the same abnormal movement. Because my father is die. I don't know. I'm not sure.
Okay. All right. Okay. All right. Okay. How has this affected you, Janet?
Yes, doctor, it's affected me so much, doctor. I can't go to the home, to the work. I can't do something in home.
Okay. And who do you live with, Janet?
With my husband.
And is it supportive?
Yes, doctor.
Oh, okay. All right. So, thank you for speaking with me today, Janet. I want to examine you at this point, okay? I want to check your vital sign, check the blood pressure and the pulse rate.
Normal.
Normal, okay. Any pallor, any jaundice?
No pallor, no jaundice.
Okay, check the mouth for any cyanosis.
No cyanosis.
Okay, so I'm gonna check for this okay, but Janet, I want you to say this after me. I want to give some instruction. I want to say it after me. Can you say British Constitution? British
Normal.
Constitution. Normal.
Yes,
Okay.
no.
Okay. Nystagmus. Any nystagmus?
No nystagmus.
Okay. Okay. Finger point sign. Anything on the intention tremor?
Yes, there's intent. I sent the video in the group. Yes, there's finger to nose test is positive
Positive on both sides.
in both sides.
Okay. This the diaconixia. Is it possible on both sides?
Yes, he can do it because the patient abnormal movement. Yes,
He can't do it. Okay. All right. So I'm also going to check for the power, the tone, the power in the upper limb and lower limb as well. Tone,
There's
power, and reflexes.
There's hypotonia.
Hypotonia. All right. And also the heel to shin on the lower limb on both sides.
The lower limb is also hypotonia.
Okay. And the reflexes?
Reflex is normal.
Normal. Okay. Are you able to walk for me, Janet? I want to see you walk.
No, doctor, I can't.
Oh, there. All right. I'm going to support you. You can't even you can't walk at all, Janet. It's okay. It's okay if you can't. All right. So, okay. Thank you for allowing me to examine you, Janet. All right. From all that you've discussed with me and what you've had, I'm suspecting, Janet, that you may have a condition that is called Huntington's disease. Okay.
Is it called what?
Huntington's disease. Don't worry about it. It's actually a big name, and it's simply a movement disorder. Okay, that happen with that is due to some abnormality in the gene, And usually it comes with abnormal movement, like the what you said you have, and also sometimes affect the mood and also the mood and also our behavior. I mean the behavior which is inconsistent with everything that you've said to me, Janet. Okay. All
Is
right.
it treatable, doctor?
Is that what?
Is it treatable?
I'm sorry, Janet. It's not something that is treatable, but it's something that we can manage the symptoms, okay? And I'm going to refer you to the specialist. That's the specialist doctor in movement disorder, who will further evaluate you with some other investigation and able to make a diagnosis. And if diagnosis is confirmed, we will be able to refer you to the MDT, where we will support you as much as we can in terms of the movements, your social way of occupational therapist, and in as much way as we can, Janet.
Doctor, I am planning for the pregnancy.
Oh, Janet, I can't. I want to. Well, planning for pregnancy, I would say when you it's okay. Okay, you can go ahead to get pregnant, Janet. Like I said, it is a genetic thing that, and unfortunately, this can be transferred to your children because of the mode at which it is inherited. Like you said to me, your father has, I don't know, your father has similar condition, which possibly may be what you are having. Okay. And there's a 50% chance that you may transfer this to your children, but that does not mean you can't get pregnant. There are ways that we can assist you when you want to get pregnant. It needs to be a planned pregnancy, and we have to get the woman doctor involved in your pregnancy, Janet. Do you have any other concern, Janet?
1 minute left.
No, doctor.
Okay. Thank you for speaking with me today. I'll give you some leaflet about this, and then we could book another appointment in future to have a further discussion. Is that okay?
Yes, doctor.
All right. Thank you for speaking with me today.
Okay, sorry for allowing late, about 1 minute or 2 minutes left. Anyway, the time is up, and I think you're finished, Dr. Ayula, right? So we can start the exam question, Dr. Rasha.
Yes, presenting your case.
Okay, I just I spoke to this young lady who had 6-month history of abnormal movement, as well as affectation of the behavior, and also mood, so some mood symptoms. There's a family history of similar condition in the dad. He has no anterior neck swelling, and there's no other feature that is, there's no rigidity, though he has some gait abnormality. On examination, there's evidence of cerebellar affectation, as evidenced by ataxia, as evidenced by the ataxia and other cerebellar lesion. So I'm suspecting that this patient would have some cerebellar I think that the patient will have Huntington's disease. Other possible differentials could be a Wilson disease, which in this patient there is no evidence of liver affectation. I also consider the possibility of Parkinsonism, which might be due to medication. But in this patient, I was not able to pick any medication because I don't idiopathic Parkinsonism is not common in this age group. So I'll be looking for other causes of Parkinsonism like medication, which is not possible, which is not positive, I mean, in this patient.
Okay. How can investigate?
For the investigation, the diagnosis is usually clinical diagnosis, and for clinical diagnosis and investigation could include a genetic testing to look out for the gene, the affected gene in this disease.
Okay, and how to treat?
For the treatment of autism disease is usually multidisciplinary approach, and it will involve the movement specialist, the occupational therapy, the social worker, the physiotherapist as well. And the management is usually symptomatic. It is not curable, but is manageable.
Okay. Regarding this, the abnormal movement, which the called this the abnormal movement?
The cause of the abnormal movement.
The what?
Did you say the cause?
Okay. What you mean Korea?
Yes.
Okay.
I get what you mean. Okay, what type of movement is it? I think it's I can't see the video, but I think it's a chorea.
Okay. What are the causes of chorea?
Other causes of chorea could include Wilson disease.
Okay.
Gosh, I can't remember now.
Okay, how to treat? Hello?
Hello, I can hear you. I'm trying to.
Okay.
Yeah, it's been a while, honestly. I
How
can't
to
remember
treat?
really.
Okay, no problem. How to treat?
How to treat?
Well,
for the treatment is dependent on the etiology, and if there is a drug, if there's a drug cause, then you want to withdraw the medication and treat the underlying cause of the chorea.
Okay, how can difference between chorea and hemiplegismus?
Okay, difference between chorea and hemiplegismus. I don't know. I'm not sure.
Okay. Okay, regarding this condition, is it curable or not curable?
It's not curable. It's only manageable.
There's any advice you wanted to tell to this patient regarding this abnormal movement?
Okay.
Okay.
Oh, no.
Yeah, the good thing you are saying I don't know better than saying wrong.
No.
Okay. Any other question, Dr. Rasha?
Okay, do you know any special test for examine the chorea?
Any special test to examine chorea? No.
Okay.
Great. Okay, thank you, Dr. Rasha. Well done, Dr. Ayola.
I'm not familiar. I'm not movement disorder.
No one familiar with Huntington.
No, yes, because this I need to discuss this the case because الابnormal disorder يعني ديما تكون فيها big problem يعني تكون فيها difficult
It's
يعني
less
difficult
common one,
case. Yes, less common, but sometime maybe come in the exam.
Exactly. Yes, you have to know. Okay, this is your turn now, Dr. Rasha. You can talk about it.
Okay.
Yes. Regarding this patient, if the patient abnormal movement, I think is the most important. The first after ask about the onset, the course duration. May I have a look? Because I've seen the patient, the chorea is the patient bilateral abnormal movement. You need to start it from at the first. May I have a look? If see the video, you can diagnose the chorea because it's spot diagnosis. Okay. After that, if the patient confirm the chorea after the scene to the patient, put into the new mind the differential diagnosis of the chorea. The differential diagnosis of chorea, write the name of chorea. The C, the Cooper's like Wilson disease. H, Huntington disease. O, estrogen والpregnancy, OCB, antipsychotic medication. R, rheumatology such as SLE, antiphospholipid syndrome. A, autoimmune disease. E, endocrine such as hypothyroidism وthyrotoxicosis. Metabolic disorder, hypoglycemia and uremic. Uremic causes. Okay. When see patient abnormal movement, you put all the differential diagnosis in your brain. Regarding the Huntington disease, the patient has the family history and problem in mood and problem to the thinking, and the patient problem in behavior change. Okay, and after that, regarding ask all the CNS manifestation from the up to the down: headache, headache, nystagmus, gait, recurrent fall, shaking to your hand. Okay, and after that, examine general symptom to rule out thyrotoxicosis and hypothyroidism. Ask about the abdominal to rule out the Wilson disease. Ask about the rheumatology to rule out SLE and antiphospholipid syndrome and other autoimmune disease. The drug history, you need ask about OCB. You need ask about pregnancy. You need ask about antipsychotic medication. And also the past medical history, you need ask about diabetes, hypertension, hyperlipidemia, because the chorea may be الcause متاعها at other differential diagnosis of chorea hemiplegismus or hemiplegismus related into the patient stroke. You need to rule out الatherosclerosis package اللي هو الhypertension والdiabetes والdyslipidemia. The difference between chorea and hemiplegismus, hemiplegismus most likely related to the stroke and to the subthalamic nuclei, and the movement is unilateral, take the upper and lower. But the chorea take all the body, even the trunk. Okay. Regarding your mood, ask me about the score of the mood. I think there's no score for the mood. If the patient have the mood problem, you need ask about if the patient have the thought to harm yourself. If the patient you said yes, you need to refer into the patient to the mood doctor, because the patient can be affected the clinical judgment. The test for the chorea, 2 tests. After the examine the chorea, do all the CNS manifestation, include the finger nose test, include the hypotonia, include 2 tests specific for the chorea, like milk sign and like tongue sign. The tongue sign, when ask the patient to open to the mouth, see this abnormal movement in the tongue. The milk sign, when you put the finger, when put into the finger into the palm of the patient do relaxation, put into the hand grip. You mean do hand grip? The patient do relaxation, and يعني when try to examine the hand grip, the patient do relaxation, which they call the milk sign.
So relaxation followed by contractions.
Yes, relaxation followed by contraction is called the milk sign. In the examination, you need to is looking for the liver disease, looking for the sign of stigma of chronic liver disease, because the patient may be Wilson. You need to examine the thyroid, because hypothyroid may be one of the symptoms. You need look if there's any joint problem, any skin rash, because the SLE one of the causes of the chorea. Regarding the investigation, CBC LFT inflammatory marker, baseline investigation to rule out the causes, genetic test to confirm the diagnosis. Regarding the patient, concern بتاعه is not improved, the condition is not improved, just only supportive treatment, such as the patient occupational therapist, social therapist, nerve doctor. Difference between the hemiplegismus, movement is improved after 1 or 2 months. Treatment of the chorea, tetrabenzene. Okay.
Yes, okay. Any further comment, Dr. Rasha, you want to add?
Yes, يعني Dr. Lula, if forget the chorea, the differential diagnosis of chorea, like just only written the chorea. After that, you remember the differential diagnosis.
Okay, can you write your mnemonic, Dr. Rasha, in the chat
Yes,
box?
F chorea C. Okay.
Yeah.
And the tests too, please. The 2 tests you mentioned for chorea.
Yes, okay.
Milk sign and tongue.
Milk sign and tongue sign.
Checking box sign.
Yes. Box tongue sign, yes?
Okay. Yes, I think the topic now is clear. It's not common, but it comes. So be ready to read it or to read this topic once. Okay, and to know the most common cause in PACEs. By the way, they will not ask you about the other causes in details. So drug induced, what drugs can lead to. You have to read it once, but it's not that much common in PACEs. But the common causes you have to know. On the top of them, Huntington disease, and it comes as communication scenario for screening, genetic screening, and counseling, or in the long clinical consultation. So you will know the case as a spot diagnosis. Whenever you see the patient with his movement, dance movement, and purposeless movement, and it's involuntary movement, you will know this is Huntington disease. According to the diet or the center and the country, which center, they might have the Huntington. I don't know which center familiar with this disease. But anyway, it might be presented as surrogate. You have to know about the disease from not all details, but at least to know the most common. We mentioned already the Huntington. You have to roll out phases wise, I mean, pregnancy, gravidarum. Phases wise, you have to roll out SLE. Phases wise, you have to roll out Wilson disease and drug induced. So all question related to each category, you can ask them in the history, either systemic review. So you have to ask about the liver disease, signs and symptoms, starting from the jaundice or the tremors or any change in the skin bruises or any infection, blood transfusion. I think Dr. Ayula covered most of these questions in a smart way. Yeah, it wasn't organized, but she covered the most common question related to each category or each cause. So the pregnancy as well, she asked about, are you pregnant by any chance, particularly in young female patient within the childbearing age? The next, the SLE and autoimmune, you have to ask about any joint pain. I think Dr. also Ayura was aware and she was focusing about the questions when she asked about skin rash or joint pain or stiffness or back pain. All these questions for the SLE and autoimmune type. The other cause, drug induced. So you can ask about show me your drug list. If not, so you will have to confirm your disease as clinically from the spot diagnosis manifestation in the video or in the patient himself, plus the family history and some other manifestation like mood change, like behavioral change. And don't forget, this disease is anticipated one, right? So there is what's called anticipation positive in this disease. By the way, Dr. Ayula, what the name of the chromosome or the gene, sorry, not chromosome, the gene, Dr. Ayula?
Yes, please, I'm here. Is my sorry, I was a bit distracted. My kids came in. Sorry.
Don't worry, no worry. Do you know the name of the gene, Huntington?
Oh, I can't remember now. Honestly, I'm just.
Anyone know the name of the gene?
One of trinucleotide repeat disorder.
Yeah, it is one of them. It's called
Mm.
Yes,
CAG, right?
yes,
CAG.
yes.
CAG gene, Dr. Bassam.
Sorry, again?
CAG
Yeah,
gene,
exactly.
repetition
CAG.
chromosome 4.
CAG, yes. CAG gene, yes. And anticipation here positive, right?
Anticipation, yeah.
So the youngest generation, they can have the disease earlier
Yeah.
at early age, earlier than the previous generation. So this patient might have this disease or
It's named poor prognostic anticipation.
yeah, exactly. That's why she might present with the disease at 20s. If her father, for example, presented at 50s or
15.
40s, she will be presented at 20s, as in this scenario. Family history
Champion,
is,
can you excuse me, please?
sorry? Okay. Sorry, Dr. Ayula. Yes, you can mute yourself, please. The family history is very important to ask in this scenario. Okay. By the way, you have to start suspecting Huntington on the top of your differential, particularly the age and family history, plus the mood change, CNS analysis in full and detailed history, starting from the movement, the weakness, the pins and needles, vision problem, any balance problem, any hearing problem, any mood change, any sleep change, and the behavior change, the memory change. All these questions should be asked as analysis of the relevant system. Okay. Then the other differential you can ask them while taking the systemic review. For example, the joint we already mentioned, the joint for SLE and for the pregnancy in the female history. By the way, birth control pills, one of the possible differential in this scenario, she is on birth control pills, and it might be the reason. So you have to put it one of the differential, drug induced or birth control OCP induced. Pregnancy as well, if she is pregnant. And I think Wilson also should be screened by the question for the liver and hepatic manifestation. Although it's not in this scenario, but you have to offer abdominal examination, examining for hepatomegaly or splenomegaly to rule out cirrhotic liver or any end-stage liver disease manifestation. These are the possible and the most common cause of Huntington, of chorea, not Huntington, of chorea in basis. On the top of them again, Huntington, and the question will go through the Huntington from the pathophysiology, what the mode of inheritance, how to investigate, how to the manifestation, how to diagnose. It is clinically, as Dr. Ayula mentioned, and finally the management plan, multidisciplinary team approach. Most of them are supportive, so no cure, no specific pharmacological treatment for this scenario. So the most important team to be offered here is physiotherapy, occupational therapist for the Korea movement, as well as any support patient need. If she is, for example, living with someone, does she need any social support? Does she need any even emotional support or any psychotherapy for the mood? Okay. It's again rare topic, but it's very important topic. You'll be unlucky if you have the case and you didn't read the topic, and you'll be lucky if you practice this case once in your training. At least do the case as a surrogate, or ask your partner to prepare this case for you to screen about the possible cause of chorea. Hemipalismus for question, of course, one of the possible questions. It's one of the differential, but the difference between both, how to distinguish between the movement of Palismus and or hemipalismus and Huntington, it's not including all the body, only half of the body. And in Huntington patient, all body will be dancing in purposeless movement. Is it clear for all?
Yes.
Okay, thank you, Doctor. Now I think you are aware to be more oriented about this topic and to be ready for the exam. Read it once today or tonight,
Mm.
and it will be memorized forever, hopefully. If you have elderly patient, don't forget the vascular cause. So the patient might have either trauma or he might have stroke. It can be also the cause. Okay. But in young patient, yes, you can ask about trauma. And it was one of the questions as well. Dr. Ayula asked when she asked about fainting. And did you fall? Yes. And any injury to your head? It's very important question. Even if you forget to mention the trauma as one of the causes of chorea, at least you roll it out while taking history. Okay. So it's important to know if he has or she has any trauma in her history, either as direct question or after asking about the balance and the patient fall down, and after falling down, did she injure herself? It's important question also to be knowing if it is trauma related query. It's one of the differential, by the way. I sent one mnemonic. It's difficult to remember all of them, but please at least remember the 5 causes I mentioned. Huntington on the top, Wilson disease, the pregnancy, SLE, autoimmune, vascular, and drug-induced, OCP. I think these are the most common related causes and paces. You have to remember while screening or taking history. Okay, thank you again, Dr. Rasha and Dr. Ayula. I prefer to bring a very rare topic rather than practicing common topic. Why? Because yeah, we practice the common topic frequently. I think the videos in the YouTube channel full of the common topic. But such topic like Huntington, one of the rarest topic to practice, and you would be unlucky to have it in the exam. So whenever you are defective in certain topic, try to do it as a surrogate, or to ask your partner to prepare for you to do it as a candidate. Okay. I sent usually the names earlier of the partners for the session participants. If you have any preference to prepare a case or to ask your partner to prepare a case for you, it's okay. If not, it's okay to practice any case and any topic. Any question, Dr. Ayula, Dr. Rasha?
No.
No,
Yeah.
thank you.
Yeah, there is also some screening for the uremia. I forget to mention the uremia and thyroid, hyperthyroidism or hypo. I think hyper. It's written hyper, not hypo.
I think
Anyway,
both
both.
hypo
Okay.
and hyper.
Okay.
Oh, yes,
So
both.
yeah, so you can mention them in the all screening. So you have to rule out every single cause can lead to the chorea, starting from the blood basic workup. So CBC, coagulation profile, even lipid profile, if you suspect atherosclerosis, thyroid function test, liver function test. In this scenario, it's not specific. You have to do all the panel for everything in this scenario. Liver function test, full labs for the liver function tests. Even you can suspect the hepatitis workup, you can do it. Autoimmune screening from A to Z, antinuclear antibody and all antibodies, you can mention them. The uremia, of course, kidney function test, and no specific image for Huntington. The specific investigation for Huntington is genetic testing if you suspect Huntington. Otherwise, you have to rule
Dr. Ram,
out.
sorry.
Yes, sure, sure.
Also we can do MRI brain in Huntington's reveal atrophy of the putamen and caudate nucleus, and also dilatation of fourth ventricle.
Okay. Thank you, Dr. Ahmed, right?
Ahmed.
Yeah, is it something usually present or it's not in all cases? The MRI finding. I remember it's not.
I'm not sure, but I read it before.
Yeah, I think so. It's clinical diagnostic, not as radiological investigation or not radiologically diagnostic.
Yeah,
Okay.
sure, diagnosis clinical, but
Yeah,
also it can give
exactly.
clue.
Yeah, it can give you a clue. Yes, exactly. I agree. Even you can rule out other causes of vascular cause, multiple strokes, for example, frequent strokes or previous strokes can be the reason. So you have to do it to rule out other possible cause, not to diagnose the Huntington itself. Okay. Genetic testing is very important. The concern of pregnancy is very important as well to know how to answer it. Yes, we are wishing or we are willing to do the planned pregnancy in order to do over selection because we can prevent the disease from running to in your kids by doing the over selection. Or if there is male, you can do sperm selection. Okay, of course, after referring the patient to genetic counseling team. It's not your job, but at least you can prevent the disease by this way. Clear for all? Okay, I will try to read the comments quickly. Anyone has comment before reading the comments? I prefer the way of Dr. Ahmed sharing his opinion, so please feel free to comment. Not only to write, you can talk, you can gain a lot of confidence while talking. If no comments, I can read the written comments here. Yeah, I think Friedreich ataxia, yes, Dr. Pacer. Yeah, this Friedreich for GAA, gene, trinucleotide disease, yes, CAG, yes, CAG, for Huntington. So tough, Dr. Muhammad Ashura. Yes. Again, what in the picture, it's not necessarily to remember all of them, at least the most common in paces wise. Huntington, Wilson, SLE. By the way, rheumatic. We didn't mention rheumatic. So you can find patient with rheumatic heart disease at early stage or at early age, and it can be presented later on as a chorea. It's called Sydenham. This is Sydenham, right? Sydenham.
Yes,
Yeah.
but I think the rheumatic in the children from 5 to the 15 years.
So you will find the
Mm.
younger patient. Yes. Okay.
Yes.
Anyway, not to remember all, at least remember the most common. It's tough. Yes, I agree. It's tough topic as well, but be ready at least once in your training to practice the case as surrogate or as a candidate and read the topic as well. Okay. Back to the comment, Dr. Aisha. So paces wise, pregnancy, SLE, Wilson, polycythemia. Yes, we didn't mention the polycythemia. Drug induced Huntington. Huntington on the top, Dr. Aisha, yes. Okay, CAG. Dr. Rasha, mnemonic. Korea. So starting by C, copper for Wilson disease, Huntington, OCP, pregnancy together, estrogen, antipsychotic for A, rheumatic, sorry, for O, rheumatic fever for R, for E, endocrine hypo or hyperthyroidism, hypoglycemia, uremic hyperglycemia, hypoglycemia, yes, hypoglycemia, I mentioned twice. Autoimmune for A, autoimmune SLE and antiphospholipid. The signs milk sign, milk, I think milk hand sign and jack box tongue. So the patient, he cannot keep his tongue out. So whenever you ask him to protrude his tongue, so he cannot maintain or he cannot keep his tongue out. Okay, for anyone, usually you can keep your tongue out, but he cannot keep it out. Dr. Ilaf, what other disease with anticipation? Yeah, Fragile X, myotonia dystrophica, Dr. Ihda mentioned already, Huntington disease. Friedreich is not one of the anticipating disease, although it's one of the same trinucleotide, but no anticipation. So the Friedreich is the only exception. Thank you, Dr. Aisha. Okay, milk sign video on WhatsApp. I will share the screen in order all can see the video. Just give me a moment so all of us can see the video.
Yes, Dr. Bassem, but regarding الhypo and الhyperglycemia and الhypo
Okay.
and الhyper and الhyperthyroidism, both.
Okay.
Mm.
Yes, so the videos are ready, so we can share the screen and we can play the video together. Give me a second. Any question before sharing the videos? Because it would be the last thing to practice or to share together today. So you can see the screen now, right? This is our patient today. You can see the video again. The screen is shared.
Yes.
Yes, we can see.
Okay. Again, purposeless movement, all the limb, involuntary. This is the handmade, yes, or hand milk. He has frequent contraction followed by relaxation, involuntary way. So the hands relaxed, then contracted again in involuntary way. The same as the milking in homemade. Okay, any other videos to share? It's clear for all? See, multiple and frequent contractions. There is temporary relaxation, but again, it's contracted again. Clear? Anyone with any question? Any comment? Dr. Rasha and Dr. Ayula? Anyone
No,
with comment?
no, thank you.
No,
Okay.
thank you.
Okay, Dr. Aisha, you want to comment? Dr. Ihda, share the file. Let's see the last thing. Okay, autosomal dominant, multiple spinocerebellar attacks, yeah. Huntington, CAG, yeah, CTG. Yes, anyone with question? I hear someone talking. Any question? Okay, the autosomal recessive Friedreich ataxia, X-linked, fragile X, no expression type, Crohn's, Behcet. Yeah, so this is the mode of inheritance in the genetic disease with anticipation, or not with anticipation, with the anticipation already mentioned with trinucleotides, repeat. But the anticipation, you can remove Friedreich ataxia from others. So myotonia dystrophica with anticipation, Huntington disease with anticipation, and the third is, I think, Huntington and myotonia dystrophica. Yeah, the third without anticipation would be the Friedreich ataxia. Fragile X with anticipation. Okay, so Fragile X and Huntington and myotonia dystrophica. Okay, but Friedreich is not anticipated one. And it's a good thing because Friedreich is multi-systemic disease, affect everything in the body. Okay, thank you everyone, Dr. Ihda and Dr. Ayula, Dr. Rashad, Dr. Ahmad, everyone shared today, attend. If no more question, we can end the session. See you tomorrow with Communication Day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you too.